Hello. So this lecture is going to be about pediatric cancer. So before we dive in, here's just a few facts and figures to give you an idea of the magnitude of pediatric cancer. So as of 2024, there are approximately 9,500 children in the United States under the age of 15 that are diagnosed with cancer. Leukemias and central nervous system tumors or brain tumors are the most common. Now, since the 1970s, the 5-year survival rate has increased from 58 to 75%. However, cancer is still the leading cause of pediatric death after unintentional injuries and accidents. So when someone has cancer, what happens? The cells grow out of control, right? They'll develop abnormal sizes and shapes. They'll exceed their typical boundaries inside the body. They'll destroy neighboring cells. And then in time, these cancerous cells can spread or metastasize to other organs and tissues. Peds cancer is the same as adult cancer, right? We do have some different types, and so we're going to go over the differences after talking about causes. So the cause is unknown in most cases. We know there's a genetic component from random mutations in the genes of growing cells, but there's really no effective way to prevent them. Some risk factors that we consider include exposure to certain environmental agents like chemicals and pesticides, radiation, especially gamma radiation and X-rays, and then even some viruses like Epstein-Barr, which causes mono. We don't know the exact mechanism, but it's believed that some viruses can interfere with the immune system and promote cell growth and proliferation. So this is why we now have an HPV vaccine, right? Preventing HPV can be effective in reducing cervical cancer. And so as we find these things out, we can work to prevent them that way. So let's get some definitions out of the way. Cellular regulation is the process by which cells will replicate, proliferate, and grow. And so cancers will cause alterations in that cellular regulation. In all types of cancer, some of the body's cells begin to divide without stopping and will spread into surrounding tissues. And then as they become more and more abnormal, the old or damaged cells will survive when they should die, and new cells will form when they're not needed. And as these start to divide without stopping, they can form growths, which are called tumors. So many cancers will form solid tumors, which are masses of tissue. But then we also have cancers of the blood, like leukemia, that do not form those solid tumors. And then they can either be benign or malignant. So a cancerous tumor is malignant, and that means that it can spread or invade into other tissues. And then benign tumors do not spread. So you can read this chart. Essentially, pediatric cancers are still quite rare. Of all cancer diagnoses, it still represents less than 1% of cases. In children, however, it's more common in Caucasian kids, while in adults, it's more common in African Americans. You also have different types. Pediatric cancers also often don't present until they have metastasized, and that's because most childhood cancers arise from tissues that are deep within the body, whereas adult cancers are often in tissues that are exposed to the environment. So we do have some screenings that we can use for adult cancers, think mammograms, colonoscopies, but we don't really have that capability with pediatric cancers. So you can see how most pediatric cancers are leukemias or cancers of the blood-forming tissues, or they can be sarcomas, which occur in bones and soft tissues. And then in adults, we have more carcinomas, and those are cancers that will affect the epithelial tissue that line your organs and your skin. This row about cooperative group treatment is referring to how we base childhood cancer treatments on adult protocols. And so they're not as individualized. Adults will have a very specific individualized cancer treatment. If any of you have had experience in oncology, you'll know this. We really use very specific treatments in adults, but with kids, we just don't have that research. And so we use a lot of protocols that have been developed in larger groups. Now, even though childhood cancers are more aggressive and they could appear over days to weeks, the overall survival rate is still a bit higher than in adults. So these are some of your most common pediatric cancers. So starting with leukemia, this is an unrestricted proliferation of immature white blood cells in the blood-forming tissues of the body. So this is a blood cancer. There's no tumors. It is the most common type of pediatric cancer, and it'll represent about 28% of all cancer diagnoses. And then there are different types of leukemia. We have acute lymphoblastic leukemia, or ALL, and acute myeloid leukemia, which is AML, and your book has more detail on the difference between those. I'm going to talk a bit more generally about them in this presentation. So signs and symptoms of leukemia, because you have that immature proliferation of white blood cells, the patients will often have severe anemia that will lead to fatigue and pallor. They'll have fevers, petechiae, weight loss, lack of appetite, and they'll often present with joint or bone pain. Your CNS tumors, these are nervous system or brain tumors that occur below the roof of the cerebellum, and usually involve the cerebellum or the midbrain or the brain stem. So your signs and symptoms here are really going to be related to that increased intracranial pressure. So you'll see things like headache, vomiting, ataxia, nystagmus, diplopia, seizures, mental status changes, right? Now, Wilms tumor is a very specific pediatric tumor, and it is a rapidly forming intrarenal lesion that will encapsulate as a tumor. And so this will often present as increased abdominal distension or a firm abdomen. These kids can have high blood pressure because of the renal artery compression, which will increase renin production. A big test question comes from the assessment of Wilms tumor, which is to never palpate the tumor, okay, because you can actually translocate those cells and cause it to spread. But conversely, this is one of the reasons why we do a thorough abdominal palpation on young infants and newborns, because you can feel it when it's smaller and potentially have an earlier diagnosis. Now, neuroblastoma, this originates in the neural crest cells and will commonly develop in the adrenal medulla along the sympathetic nervous system pathways. So this could have a lot of different symptoms depending on where that tumor location is, okay? They'll often have some pain in that location. Some kids will have an abdominal mass. You'll have those non-specific signs like fever, fatigue, weight loss, and pallor with those neuroblastomas. Bone tumors include osteosarcoma and Ewing sarcoma, and these are tumors in the bone. They could have painless or painful swelling. It depends. A lot of times these would be diagnosed from a fracture that's unexplained, and they'll catch the tumor during an x-ray. And then the last cancer we're going to focus on is retinoblastoma. This is an intraocular mass of the retina. You might have heard of this. These have historically been diagnosed sometimes with flash photography, and this is why we do a red reflex with patients, because when you have that light bounce off the back of the eye, we can see a whitish glow called leukocoria, and sometimes we will not see that red light that we're looking for. And I imagine, since we don't use cameras with flashes so much anymore, I'm sure that a lot of you don't have all of those fun little childhood photos where everybody has red dots in their eyes like I do. I wonder if home diagnostics here, the rate of families finding this out and bringing it to their physicians has decreased because we just don't use the same sort of technology anymore for taking photos. So some cardinal symptoms of cancer include fever and pain, and those are obviously really common in a lot of childhood disorders. So they're pretty easy to miss, but we really want to look at the big picture here and the progression of symptoms. This fever can be prolonged or unexplained. They could have pain at the tumor location. A tumor might cause limping, for example. We'll see decreased PO intake leading to weight loss, and this can actually be very rapid. Anemia related to improper bone marrow function because it's not producing red blood cells like it should. Sometimes you might have bruising or prolonged bleeding due to the bone marrow supply suppression, and they'll have low platelets. You might see neurological changes from increased ICP. They might have those frequent headaches with emesis, which is always a concerning sign for some sort of neurologic pathology. Same with like sudden vision changes, gait changes, level of consciousness, that sort of thing. So we'll do a complete H&P, and then we're going to be looking at a CBC with diff, right? Mainly looking at hemoglobin, platelet count, white blood cell count, because for example in leukemia they would have low platelets, low hemoglobin, and then either low, normal, or high white blood cells. Think about if platelets are low, what are we concerned about, right? Sources of bleeding. So the parents might report that the child's gums bleed more while they are brushing their teeth, okay? You want to pay attention to those signs. Well, they're going to need baseline liver, kidney, and electrolyte studies so that we can monitor the extent of disease, and those will continue throughout therapy. We're going to be constantly watching the labs to see how the body is responding to chemotherapy and radiation. Chemistries and UAs are standard procedures also to monitor for side effects. We want to know how their immune system is handling the treatments, but we also want to know how their kidneys are handling the treatments. So we might also look at uric acid levels, because any renal insufficiency where the kidney has trouble filtering waste could affect dosages of chemotherapy. As far as diagnostics, continuing on, LPs, mass biopsies, bone marrow aspirations, those can all look for things like metastases or types of leukemia. We'll be looking in an LP, for example, for cell count and presence of blasts. The mass biopsy will just give you a direct indicator of what is going on with that tumor to help diagnosis. And then obviously any other tests that might be relevant, because cancer can affect the body in lots of different ways. And so we will use whatever seems relevant to determine what is going on. So here's just some reference photos because I think photos are fun, showing how some of these cancers might show up. We have a blood smear from ALL compared to a normal blood smear. Here you can see a glioma in the brain. There is an image of an osteosarcoma or a bone tumor. Then this child in the upper right has neuroblastoma of the abdomen. You can see how large and distended he is. Below that, we've got Wilms tumor, and you can see it with the little arrow showing up in the scan. And then this leukocoria that you would see in retinoblastoma. The treatment is dependent on the type of cancer, and this is outlined more specifically in your text, but we're going to be reviewing surgery, chemotherapy, and stem cell transplants. We have two different types of surgery that we can do. We have diagnostic, and that's meant to biopsy the mass or the metastasized area. And then there's debulking, which is what we use to reduce as much of the volume of the tumor as possible. So this would be surgical removal, and this can be done before or after other therapies. The main goal of all of these phases is to restore normal body function. So for example, with an osteosarcoma, surgery could remove the diseased portion of the bone instead of just amputating the whole limb, right? So that we can preserve function as much as possible. Chemotherapy, as you are probably aware, kills indiscriminately, so that's why the side effects are so awful. Malignant cells have a very limited ability to repair themselves when injured compared to normal cells. We aim to kill off those malignant cells knowing we're going to damage the normal ones, but the normal ones will come back. So you'll lose your hair, but your hair will come back, right? Chemo regimens are a combination of multiple drugs. They could be cell cycle specific, and patients could be enrolled in a study during treatment. That's pretty common. We also want to do supportive medications like antiemetics, pain medications, and nutritional support. Keep in mind that chemo is also very toxic to the veins, so patients will often have a central venous catheter like a Broviac or a Hickman or a PICC line so that they don't risk any damage from infiltration. So a potentially fatal complication of chemo is anaphylaxis. As with any medication, we need to take a careful history of known allergies, recognize the signs early, and to teach patients and families to look out for these as well. This list should be pretty familiar as it's come up, I'm sure, a lot during school. The standard of practice for chemo admin is to observe the child for an hour after the infusion so that we're monitoring for those adverse effects. We'll always have emergency equipment at the bedside and access to emergency drugs via code cart. You'll want epinephrine, antihistamines, corticosteroids, right? If you notice that the patient is beginning to have an anaphylactic reaction, we're going to call a rapid response. Stop the drug, flush, just like with a blood transfusion, and maintain that IV because you need access to that IV to give them that life-saving medication. We'll be taking vitals, making sure their airway, breathing, and circulation are okay, and notifying that ordering physician, and the rapid response team should also bring a physician to the bedside so that we can treat them properly. So now let's talk about radiation. So this is usually used in conjunction with chemotherapy or surgery. It can be curative or also for palliative care, just to help with pain management and make them more comfortable, okay, or more functional in their life. So we could do whole body radiation or very precise radiation. It really depends on what we're trying to do here. If you are doing very targeted radiation, you could have burns in those areas. We can often see that because of the rapidly dividing cells, they're dividing and causing damage, which can lead to those side effects. Now, stem cell transplants are most commonly used to treat leukemias, neuroblastomas, and some brain tumors. And as we mentioned during the hematology lecture, there are now actually some non-cancerous conditions that we can treat, like sickle cell anemia and beta thalassemia. Stem cells are basically the body's raw materials. Okay, they are the cells from which all other cells with specialized functions are generated. So essentially, a stem cell transplant will rid the body of all cancer cells. And then once the body is free of those malignant cells and that immune system is suppressed to prevent rejection of the transplanted marrow, that new marrow is given to the patient via IV. And then soon after the transfusion, those new stem cells will begin to produce non-malignant blood cells. So how this works, which is actually cool, is that prior to the stem cell transplant, when they know they have stem cells from the patient or from another patient or a sibling, they have that donor, right? They will have high doses of chemotherapy combined with about 7 to 20 days of radiation and therapies before that infusion. And why we're doing that is we want to completely kill off all of those malignant cells and the immune system, okay? Because we don't want rejection. And so once this process is started, there's no stopping. okay? Because without a rescue of a stem cell transplant, this will be lethal to that patient. So you cannot start this process unless you have stem cells ready to go. Usually once you've done the transplant, you're going to need 2 to 6 weeks for those cell lines to start recovering. So there is a lot of supportive care for these patients during this time. They're going to be in the hospital. They're going to need lots of antiemetics for nausea from that high dose chemo, lots of pain control. They're usually on PCA pumps because their pain can be so severe. They'll be on TPN. They have very high risk of infection because you've essentially killed off their entire immune system. So we're going to give them also medications to prevent graft versus host. These patients are really sick. It can be a very long and painful process. This is a picture of what this patient's IV pool may look like during a stem cell transplant. So if you like complexity, this might be a population you would consider working with. As you can see here, lots of IV fluids going, as well as several syringe pumps. Also, if you look closely, you can see the beads hanging on the pole, and these are courage beads. Some hospitals will stream together these long strings of beads, and each bead signifies something that the patient went through, like an IV poke or a lab draw or an x-ray, and they'll accumulate these very long beads of courage that become a visual representation of what they've been through. So I think that's pretty neat. So some side effects of chemo and radiation and cancer treatment in general can happen during treatment, or they can happen 7 to 10 days after chemo. It usually takes about 3 to 4 weeks to recover once the chemo has stopped. Patients are very tired, and they're often on neutropenic precautions, which means that their immune system is depleted. So nausea and vomiting is common. So we'll usually instruct them to have small meals, and we'll be giving them an antiemetic regimen. The primary goal here, though, is to prevent the nausea before it even happens, right? Especially in kids, because just the thought of becoming nauseous can be very fear-inducing, and so they might refuse to eat if they think that they're going to be nauseous. So we will pre-medicate, and then we will usually give an antiemetic around the clock for about 24 hours after chemo to ensure that we have them covered. Also, because of these food aversions, a lot of times we'll be coaching the parents to avoid those favorite foods that the kids might have so that we can preserve it for them. Because if they become food averse during treatment, they might never eat pizza again. And if that's something that they love, we want to make sure that they maintain a good relationship with those foods. For mouth ulcers, we encourage really good oral hygiene, pain control for the mouth, and soft foods. They'll often have constipation, so we'll be using stool softeners and increasing hydration and fiber. And then to combat weight loss, these patients will often maybe have IV nutrition and lots of supplements. So this is an image of mucositis, which is a side effect of several different drugs, usually chemotherapy. And so these patients will get ulcers or inflammation of the mucous membranes. And so characteristically, they'll get these red, rounded, painful oral ulcers. Just recall that your oral mucosa continues all the way through your GI tract, right? So they can actually get lesions all along the esophagus and into the colon. And so this can make it really difficult and painful to eat. So that bland, soft diet is important. We'll recommend using a toothette, which are those green oral swabs instead of a toothbrush, to help reduce pain. Frequent rinsing, pain medication. There's actually something called magic mouthwash, which is a combination of medications to soothe these ulcers. It usually includes like a Maalox, like an antacid, a Benadryl, and then a lidocaine for pain management. So what is the goal of cancer treatment? We want to destroy tumors, right? And when cancerous tumors break down very quickly, your kidneys have to work really hard to remove all the substances that were in those tumors. And if they can't keep up, you can develop something called tumor lysis syndrome, or TLS. So we have a couple different medications we can give for this. Allopurinol will inhibit production of uric acid, and it's not a long-term medication. And there's also rasburicase, which will convert existing uric acid into a more soluble product that can be eliminated. And we'll give this IV based on urinalysis levels, and usually only give 1 dose at a time. This is often more common in blood-related cancers like leukemia and lymphomas, and it'll usually happen within a few hours to several days after the first chemotherapy treatment. It is pretty serious, and it could require dialysis to remove the uric acid if the kidneys really are having trouble keeping up. So septic shock is another emergency, and that's usually from an infection that is secondary to immune suppression in these patients because neutropenia puts them at greater risk. They also have inadequate neutrophil function and often have a central line, so there's lots of infection opportunity here. The clinical manifestations of shock are pretty familiar to you as well, I'm sure. Hypo or hyperthermia, tachycardia, tachypnea, mental status changes, perfusion issues, hypotension, neutropenia, right? Oncology patients are always instructed to be seen at the first sign of a fever, especially if they have an IV line and access, because this will be regardless of their ANCs, right? They'll receive broad spectrum antibiotics. They might receive several in addition to some antifungals to improve outcomes. Hydration in these patients is really important, so boluses or a higher maintenance fluid rate, because we want to keep them hemodynamically stable and combat those insensible fluid losses. Some patients might even be on prophylactic antibiotics like a Bactrim pentamidine combo to prevent a complication called pneumocystis pneumonia. Keep in mind that there are no rectal temperatures, enemas, or suppositories on these patients. Okay, there is an increased risk of perforation and infection and bleeding in those mucosal areas, so we really need to protect that tissue. So I mentioned ANC, or absolute neutrophil count, in the last slide, and your book talks about how to calculate it, but it's really just a measure of how the immune system is functioning. So 1,500 is normal. Less than 1,000 is okay, right? You'll have an impaired ability to fight infection, but be cautious when your ANC is less than 500, because that's when you hit a very serious risk of infection. So at that point, that means you're staying home. You're not going to school. You're being very careful. At this point, your typical signs of infection actually are absent because the body can't mount that immune system response. So you might not see erythema or warmth or pus to a localized infection. We might only see fever. So it's really important that we're being really careful and closely monitoring these kids. Any child with a fever and less than 500 ANC is at risk for septic shock. Now, how do we communicate with children about their cancer diagnosis? The best model we have is to be honest and open, to encourage parents to tell their children about their diagnosis and their treatment plan. They're going to know something is wrong, whether or not we tell them. So being honest with them and transparent is really helpful for them to feel involved and in control. Kids really feed off their parents' responses and emotions as well, so it's really important to have the parents be able to process their own feelings separately from their children, okay? We're always going to involve child life, chaplains, social work. Most pediatric cancer units have a dedicated staff that work with this population all the time. We really want to use developmentally appropriate communication. We've been talking about this all through the semester, so this is going to come up this week on how we talk to them about these things, looking at their developmental age and appropriately communicate with them based on what we know, and often acknowledging that regression is going to happen and working with them through that. There are lots of really great resources for families out there, including vlogs on YouTube. There's books to help communicate with children and their siblings about what is happening. Remember that the sibling involvement here is really important as well. This is a whole family that we're treating as one patient, and so we want to be really comprehensive in how we support them through this. As far as options for preparing for home, we can let parents know about all of the ample resources that are available to them independently. Cure Search is a website, parental support groups, specific disease-sponsored websites. There will be extensive teaching by nurse practitioners, nurses, home health nurses, child life, social work. Okay, we want to provide them with all of the equipment that they're going to need at home, right? Emergency kits for their central lines, what to do if it gets clogged or if it gets displaced. We're going to provide them thermometers, right? Not everybody has a thermometer. We need to understand where the parents are in their ability to learn at the moment. Where are they mentally, emotionally, cognitively? These kids should avoid the sun. Certain chemotherapies are known to increase damage to the skin. So we need to make sure that they're staying out of the sun. They need to know when to call the oncologist. So when we're thinking about them going back to school, we're looking at accommodations. A lot of these kids are going to have IEPs to allow for extra breaks, longer test times, staying inside if it's really hot out. Right? Essentially, we want the family to maintain normalcy as much as they can, uphold those household rules. Don't give in and give up and allow. Sometimes these kids will have behavior changes because of the stress of the diagnosis, and we want to make sure that we're supporting the siblings. We really want to teach parents the importance of self-care, of supporting each other, of having their own network, and using those outside support systems. I already talked about returning to school, so you can read this on your own. We mentioned IEPs, obviously educating the staff and the school nurse and what to look for, being aware that absences are probably going to occur. Now, life after cancer, okay? We're going to be doing lots of long-term follow-up with routine scans, blood work, hormonal screenings, hearing tests. Chemo can cause a lot of damage, and so we want to monitor for any effects of the treatment over time. And we are always following up because there's always a risk for that cancer to return. So we're going to be monitoring a lot of things chronically. What effects are there of the surgery? Have they developed any adhesions? If there were amputations, how is that going? Effects of radiation can include growth delays, hormonal imbalances, learning disabilities, cognitive delays, delayed puberty. Chemo can cause vision and hearing impairment, right? Cardio and pulmonary toxicities, learning and behavioral delays. And then are there any secondary tumors that we are dealing with as well? And then also the psychosocial impact, coping issues, self-esteem, PTSD, anything that might come up for the family, even obtaining health insurance or securing employment, because these families are in and out of the hospital a lot, and that can be really stressful for caregivers. So palliative care is the last thing I'm going to touch on. This is the last slide, and this focuses on comfort, okay, not just dying. So palliative care can be introduced at any time during a cancer or chronic illness journey. It's really important to set goals with the parent, the child, and the healthcare team by being honest. Treatment here will involve pain management and symptom control. We want to explain what the options are, what the impact will be on the patient. This will include educating them on what death looks like and sounds like. A lot of people don't know, right? Giving them the signs and symptoms to look for: feeding intolerance, changes in level of consciousness and breathing, loss of bodily function control. It's important to remember that grief is individualized and will vacillate in stages, right, between anger and denial and guilt, all those things that we've learned about. There's going to be shock, panic attacks. Parents are going to be dealing with their loss of role as a parent. Siblings will be dealing with their loss of role as a sibling. So we really want to be honest and supportive of everybody involved and allow everyone to participate as they are able and ask questions, and really support their expression or lack of emotions, even with validation. And what about you? You are also part of these families' lives, especially if you're working in peds oncology, and it is okay to have a response to a patient dying, and not just in pediatrics, okay? It is okay to attend funerals and wakes. Families are usually grateful for presence, as you're some of the only other people who truly understand what they've been through. It's okay to show families that you are human, all right? I tell new nurses this a lot. You are human, you can have feelings, but you do need to be able to comfort the family and focus on them when appropriate. So as staff, it's really important to know what your resources are in terms of debriefing with other coworkers or chaplains or social work. If needed after a patient death, really work to recognize your own coping strategies. Be sure that you have your own support system so that you can deal with these things, because we are in a profession where death does happen, and you are allowed to have feelings about it, and you should have ample support to work through that, because you're going to need it. All right. So this concludes the lecture on pediatric cancer.